the host immune status, and it includes acute retinal necrosis, which we find in immunocompetent individuals, progressive outer retinal necrosis, and CMV retinitis, which we find in the immunosuppressed individuals. First, we are going to encompass the anterior uveitis we see in the herpes simplex and herpes zoster. It's associated with trabeculitis and hypertrophy, as we all know. There may be corneal, active corneal disease or present or not. The most common finding which we find in anterior uveitis in herpes simplex is sectoral iris atrophy, as you can see in this picture. This is the most common finding that we find in this herpes simplex variety. And also there may be spontaneous hyphema present as well. The anterior uveitis in Bacillus zoster, it affects about 50% patients with the herpes zoster ophthalmicus, and mostly it involves it is present when the rash involves the side of the nose, which is called the Hutchison sign. So in all these patients, we have to do a regular follow-up for about 6 weeks from the onset of the rash, because this uveitis is mostly asymptomatic. Coming to the treatment for both varieties is topical steroids and topical cycloplegic in combination with oral acyclovir. The dose between the two varieties is different. In herpes simplex, it's 400 milligram 5 times a day for 5 to 10 days, and in zoster, the dose is increased to 800 milligram twice a day for 7 to 14 days. The alternative to acyclovir are famciclovir or valacyclovir. In case of active epithelial disease, you may delay the steroids, or you can use a topical antiviral. If there is raised IOP, then you can add the anti-glaucoma medication. And to prevent the recurrence in these patients, you can give maintenance therapy, that is about 400 milligram once a day for about a year, which can reduce the recurrence for about in 50%, almost 50%. The recurrence is reduced in these patients. This is a study which was carried out. The key points of hepatic eye disease studies were that the patient who has herpes simplex stromal keratitis, in these patients, if topical steroids are given, it will speed up the recovery and reduce the progression. Second point in the conclusion of the study was that adding oral acyclovir to these patients who are already on the topical steroids and topical antiviral, it will have no beneficial effect. So you may not have to add the oral if they are already on the topical antiviral. The third point was the patient, if he has a iridocyclitis, that is, if uveitis is present, then you have to add the oral cyclovir in these patients after 3 weeks of treatment. Now coming to acute retinal necrosis, it's a rare but devastating necrotizing retinitis, affects individuals of all ages. Males are affected more, and it's a biphasic disease. That is herpes simplex virus in younger patients and VZV in older individuals. Its presentation is initially unilateral disease, but if there is no treatment given to the patient, then it can progress within, it can involve the second eye within 6 weeks. And in that case, the disease is called BARN, which is bilateral acute retinal necrosis. The involvement period may be 6 weeks or more than that. So patient presents into there is sets, that is in one case it may present with severe visual impairment and associated with pain, and it may as well have insidious onset with a presentation of floaters. Now the diagnostic criteria for this American Uveitis Society criteria for diagnosis of ARN, there should be one or more foci of retinal necrosis in the peripheral retina, rapid progression in the absence of antiviral therapy, circumferential spread, occlusive vasculopathy with arterial involvement, prominent vitritis and anti-HM inflammation, scleritis and pain, it may or may not be present. Now this is a picture of acute retinal necrosis. ARN, it starts with moderate to severe vitritis, and it involves with multiple foci of necrosis in the peripheral retina, And if there's no treatment given at this stage, within 10 to 5 to 10 days, there is a rapid progression, and these all areas they coalesce in a circumferential pattern gradually, and this is the advanced disease which we see. About that is a posterior involvement in this case, ARN, it's late, very late. So the acute lesions they resolve in about 6 to 12 weeks, and they leave behind transparent necrotic retina, and it can be that is distinguished from the normal retina by a well demarcated line or hyperpigmented border where the retinal tears or retinal breaks appear. Most in about 70 to 75% of cases, which leads to the retinal detachment. PORN, that is progressive autoretinal necrosis. It predominantly is seen in AIDS patients, also in immunosuppressive or drug-induced or drug addicts, caused by varicose zoster virus. Same as in ARN, multifocal patchy areas of autoretinal necrosis. However, we can distinguish it from ARN. That is, first of all, it's in immunosuppressive and AIDS patient. That was in immunocompetent patients. Secondly, it's rapidly progressive, more progressive compared to ARN. And in this case, inflammatory cells are absent in the vitreous and vascularity is less prominent, and posterior poly is involved earlier. This is a picture in which the posterior PRN in which the posterior poly is involved earlier. And also in PRN case, the bilateral involvement is more, that is 70 to 75% cases both the eyes are involved, and there is more outer retinal involvement. Diagnosis may be clinical, but for definitive diagnosis, you can go for PCR based diagnostic assay of varicose zoster virus DNA in the vitreous sample. Now, CMV retinitis. It's an opportunistic ocular infection, but its incidence has greatly declined due to the advent of HART, which is highly active antiretroviral therapy, and is characterized in two forms, that is fulminant and granular. In fulminant, there are widespread hemorrhages and necrotic areas, whereas in granular, the hemorrhages are less prominent and the necrosis is also less. This is a picture of fulminant variety. It's also called physiopia appearance, widespread hemorrhages and necrosis seen. And this is a picture in which more peripheral, the granular form in which more peripheral retina is involved, hemorrhages are less, and the edema is less. There is also a subvariety which is called frosted branch angiitis. It's a picture of that variety in which there is perivascular sheathing. Again, in this case, the diagnosis is clinical in immunosuppressive individuals. Now, coming to the treatment of ARN and PRN, it differs to a little extent. It is in ARN, intravenous acyclovir is given. It's like 10 milligram per kg body weight for 8 hours for 8 hourly for 7 to 10 days, and then after that we switch to oral acyclovir, which is 800 milligram 5 times a day for about 6 to 12 weeks. In severe cases, you can add intravitreal, genciclovir, and systemic steroids. Systemic steroids they should be induced. That is started. Usually it should be started 24 hours after starting the antiviral therapy. PRN. In case of progressive autoretinal necrosis, intravenous phoscarnate and genciclovir are given, and also because it's more severe variety, so along with intravenous phoscarnate and genciclovir, you should also start intravitreal phoscarnate genciclovir 1 to 2 times per week for 2 weeks. Because there is high risk of retinal detachment in this patient, so prophylactic laser photocoagulation can be done in these cases on the posterior edge of the advancing retinitis. CMV. The treatment of CMV is intravenous genciclovir 5 mg kg twice daily for about 2 to 3 weeks, and then it switched to 5 mg kg twice a day for a maintenance therapy. 80% of patients they respond to therapy, but 50% again relapse. So, along with intravenous Jansi clover, you should also give intravitreal Jansi clover for beneficial effect. As an alternative to this intravenous Jansi clover is Jansi clover slow release device, which is named as Vitrasert. It is suspended in the vitreous that is suture sclera. Its efficacy lasts for 8 months and it's superior to the intravenous Jansi clover. Thank you.
जनरल हॉस्पिटल में और वहाँ पे एक पेशेंट है तो उनको आप इनडायरेक्टली बुलाया जाए तो शायद आपको भी इस तरह का पेशेंट लग रहा है मेरा ख्याल हमारे इस तरह के बर्ड का भी कुछ काम हुआ है
एक तो ये है कि मैं जैसा पहले भी कहता रहा तो इन्फेक्शंस आर वेरी कॉमन इन पाकिस्तान एंड ऑल द डेवलपिंग कंट्रीज सो जब भी यूवीआइटिस हो कोई भी डिजीज हो वी कीप द इन्फेक्शंस नंबर वन इन्फेक्शंस में भी बैक्टीरिया एंड वायरसेस ये बहुत कॉमन है अनट्रीटेड इंसिडेंस बहुत ज़्यादा है जो इंट्राओकुलर प्रेशर का राइज है वो इट कैन अकर इन एनी यूवीआइटिस बट स्पेशली इन herpes because it can lead to trabeculitis inflammation of the trabeculum. This is one way in which intraocular pressure can be raised. The other one is what is the other more steroid induced भी हो सकता है और सैनिकिया फॉर्मेशन के बाद पेरिफ्रंटिया सैनिकिया के बाद और good so clogging of the trabeculum because of the inflammatory cells so there are multiple ways of why the intraocular pressure increases so in all the inflammations uveitis IOP should be checked especially in herpetic. And secondly, all the chronic uveitis can lead to macular edema. So we can have OCT to measure the retinal thickness. Then these are the common features of all the uveitis. Glaucoma and macular edema, posterior uveitis cases. The one thing is that in herpetic uveitis or in keratitis, the corneal sensations are reduced and the KPs are distributed all over the corneal endothelium like Fuchs. So in Fuchs and in herpetic uveitis, the KPs are small and they are distributed all over the cornea. In all the other cases, the KPs are distributed where? Arch or triangle with the apex or towards the center. So, how you detect the iris atrophy? Now, if it is superficial iris atrophy, it is visible. But if it is atrophy of the posterior layer, how would you appreciate it? Or transillumination. So you throw the light through the pupil. When it is reflected from the retina back, you can see the transilluminated iris defects. Now, this herpes simplex and zoster are all also included in the torch infections, the congenital infections. So, if you see a corneal opacity and you decide to have corneal transplant, there may be retinitis and increased intraocular pressure damage. So, the prognosis is guarded in such cases. ये ऐसे आप सिर्फ कॉर्नियल ओपेसिटी देखते आओगे यार इसको मैं करूँगा ग्राफ्टिंग करूँगा तो ठीक हो जाएगा पीछे के क्या हालात हैं so in all the uveitis cases you have one thing in mind that posterior segment may be involved so we miss many posterior uveitis cases because of the overload we do not dilate every case of uveitis. You see, the herpetic uveitis, presents as pan-uveitis. So there is slight anterior segment inflammation. What I have noted, not here but in other places, they will start the topical steroids. ओ पे आ जाते हैं, ठीक है. So unless we dilate the patient, see the fundus, and see the other eye also, we are liable to miss these herpetic posterior uveitis cases. And as he has rightly pointed out, energetic treatment with antivirals is required. Otherwise, the retinal necrosis occurs, rheumatogenic retinal detachment can happen because of the retinal tear formation and all that. The CMV retinitis has a typical appearance. Uh, Good. Any other fancy name? Pizza. Good. Pizza pie or margarita pizza. So all these वो सालिक साहब कहाँ हैं उनके मतलब की बातें हो रही हैं. So margarita pizza, pizza pie, tomato ketchup, और वो आपने क्या बताया? Tomato splash. So all the there is a creamy background and overlying hemorrhages. So all these fancy names are given for CMV retinitis. Fortunately, it is rare here because AIDS is not very frequent, and immunosuppression. See, the in the Western countries, many a times the immunosuppression occurs in renal transplant cases, and all. We don't have much of renal transplant cases, so there are less patients on immunosuppressives in our setup. बट इट्स अ कॉमन फाइंडिंग हियर. सो आप बाहर एग्जाम देने जाएं तो ये डिजीजेस जो उनकी हैं उसको जहन में ज़रूर रखें. CMV retinitis is one of them. Otherwise, in Western countries, the infections are less, but in AIDS patient, all the infections, the incidence is increased. एसाइक्लोविर की टैबलेट कितने मिलीग्राम की होती है? 400 milligram. 400 milligram, 2 tablets 5 times a day. ठीक है, तो ये नहीं कहना जी हम 500 मिलीग्राम की 3 times a day देंगे, नहीं. टैबलेट ही 400 मिलीग्राम है, 500 की कैसे देंगे आप? सो 2 tablets 5 times a day फॉर 5 days, ये आमतौर पे आप एक्टिव वायरल डिजीज में साथ देते हैं. Similarly, in disciform keratitis, we start the antiviral ointment along with the steroids. So, in viral diseases, because there is active virus replicating in the tissues, so we always combine the antiviral with the steroids. Otherwise, the flare up of infection can take place. You see, in infective cases, you start the antibacterial or antiviral treatment and see if the patient is responding, then you start steroids. So, the role of steroids is secondary. It is necessary, but the first thing is antiviral or antibacterial. Any comment?
सर पेशेंट जब भी प्रेजेंट कर रहे हैं अगर लेट प्रेजेंटेशन भी है डिजास्टर की तो फिर भी एंटीवायरल स्टार्ट कर देना चाहिए.
So you see, you have to see whether the disease is active or not. So if patient presents with chorioretinal scars, then there is no requirement for antiviral. But if it is an active retinitis with fluffy margin and cotton wool spots and yellow-white color, that means that the active inflammation is taking place there. So you will have to stop.
So this is if you start with within 3 days of onset of the diagnosis, and they are good for preventing post-herpetic neuralgia. That is very effective in reducing that. Otherwise, post-herpetic neuralgia, you know how severe it is and how distressing it is for the patient.
So take home message is that in every case of even slight anterior chamber reaction, dilate the pupil, scan the posterior fundus and see the other eye for chorioretinal scars or chorioretinitis active lesions. Right? Thank you very much.
I'm really thankful for your all